Hello, and welcome to Ask Dr. Dawn. The opinions expressed in this program are those of the speakers, and this is a program intended for education and entertainment. It should not be construed as a substitute for a medical consultation. Let's start out with our first email, and this one comes all the way from Israel, from Shal, and Shal is a fairly regular person. Haven't heard from you in a while, so I'm glad to see that you're still doing well. I know, as the great Betty Davis would have said, it's been a bumpy night, and so I'm very pleased to hear from you. So what Shal writes, I would be glad to hear your opinion, which I respect. And then he sent a 30-minute MP3 by something called buzzsprout.com. I did not, in fact, listen to the MP3. I did, however, Google the topic of the MP3, which was mouth taping. And then I decided that I sort of knew what was going on here and found an amazing and very useful article, which I'm going to share with you. It was published in American Journal of Otolaryngology, which is a peer-reviewed journal. You always want to look for those. And it's called Nocturnal Mouth Taping and Social Media, a Scoping Review of the Evidence. And that is a pun for those, for the uninitiated, because when we look in someone's throat, that's called a laryngoscopy, and scoping is to scope, or was he scoped, is the term of art. Now, this was one of those studies where they go back and do a literature review and then assess studies. So this is a literature review. It's not a study where they combine papers and then reanalyze the data. That's a different kind of study and usually done to raise the numbers. This is just essentially a critical review. There weren't a lot of large studies, surprise, but they did review some videos and used those for what are the claims being made. They found 177 studies, and of those, they found about a grand total of 7, which were worth discussing in terms. This is the first comprehensive review that's been done. So let's cut to the chase. Conclusions about mouth taping are prominently extrapolated from claims about the positive impacts of mouth taping. It all starts way, way back. It starts in 2020. When a book was published, Breath, The Science of a Lost Art by James Nestor. Part of the book talked about mouth taping. Let's define that for starters. Mouth taping involves taking a piece of standard size, not Scotch tape, but bandage tape, and taping from the base of the nose, where you have a 90-degree angle to your upper lip, down across your upper lip and down onto your chin through the center of your lip. And the idea here is that it keeps your mouth from falling open overnight. And conclusions about this, there's been a lot of discussion in the popular press and on social media, lots of opinions, but basically the data just isn't there. So let's talk about some of the many things that are supposedly going to be helped by mouth taping. And the social media content is really just kind of amazing. So the most common claim is that it resulted in a more refreshing or better sleep. No data. The most common benefits were claims related to oral health, preventing of cavities. 24 of them said that. No data. Morning bad breath, 22%. No data. Dry mouth, 18%. No data. 16% of the study suggested using mouth taping to prevent snoring. There's one study, which we'll talk about. 6% claimed it could improve or cure sleep apnea. And oddly enough, there are 5 studies on that which actually do show some promise for mild sleep apnea. And we'll be getting to that in a moment. So one video said it would increase snoring. No data. 4% of the TikTok videos said it could be bad for individuals with sleep apnea, allergies, asthma, or nasal obstruction. Several said it would improve asthma. Actually, data to the contrary. We'll touch briefly on that. 24% of the reviewed TikToks featured medical professionals. Only 2 out of 177 actually referred to any research studies, and basically most of the claims on the internet were bunk. So it really depends on what you're trying to fix. Will it help you have better dental hygiene or reduce cavities? No data, probably not. Most of us do, even if we breathe through our mouth, we do swallow and we do generate some saliva, which you do need saliva for cleaning your mouth. Let's talk about sleep apnea. I think that's where mouth taping actually does show some benefit. This was a before and after study using 20 patients, mild sleep apnea, witnessed mouth breathing, and reported dry mouth. And what they found was that mouth taping actually worked. The number of apnea events went down from 300 per hour to 121. The amount of times that the people dropped their oxygen was substantially lower. And we're talking about p-values here that are really respectable. I mean, you probably know that 0.05 is considered statistically significant. 0.01 is pretty darn good. We're getting into the territory of 0.0002. Another study that was significant. So what we found there was in mild sleep apnea, it was really, really helpful. In severe, it was less effective, but they didn't do the study in that many severe people, except the ones who were already using masks. And they did find a substantial improvement. This one at about 0.01. So pretty good, 1 in 100 chance that it was fake. And they showed that in people who do breathe through their mouth and are using a mask that fits over both their nose and mouth, the taping helped. And that's because if you put the mask over both the nose and the mouth, some of the air goes out of the mouth and not down into the airway. So by taping the mouth shut, you improved the effectiveness of the oral nasal CPAP. On the other hand, it helped with nasal CPAP. It eliminated the performance difference. So getting air leak through the mouth during oral nasal CPAP decreased the effectiveness. So yeah, nasal CPAP with mouth taping, probably the best method overall if you aren't sensitive to the tape. There was one study that looked at snoring, and it was kind of a badly designed study. They looked at using a mandibular advance device versus about 6 things: combined airway and positional therapy, make the mouth tape the person, give them a nasal dilator, give them a neti pot lavage before bedtime and throw some steroids in there, and do things to encourage side sleeping. So sleeping partners were happy because all of the therapies helped with snoring. But the mouth taping, because it wasn't examined in isolation, probably won't do the trick for snoring. And then asthma, actually not really helpful, even though there's lots of claims that it helps. This was a good study, 50 people. People were using it for 4 weeks. They did not see any improvement in respiratory testing. They did find that people who have to use nasal bilevel ventilation for respiratory failure during sleep is a very rare neurologic condition where you don't breathe enough during sleep and your oxygen levels drop. The mask worked better with mouth taping, and you didn't get as much CO2 accumulation. So basically, this thing is overhyped majorly, like most things on the web. And I want to emphasize, folks, probably because I use my browser mainly for doing shoe shopping and looking for bargains on eBay and science. When I search a science topic, the science stuff climbs right to the top. The trusty little beast just brings me American Journal of Otolaryngology, because you bring me 6 things and one of them's a published journal article in a peer-reviewed journal. That's the one I'm going to click on. And hey, that little learning algorithm has got me sussed. That being said, if you go to Google Scholar, it pre-screens for you. So you could have gone to scholar.google.com because, for me, it just pops right up there. So I just click it. It's really good. It would have turned this article up for you, and you could have seen for yourself from just reading the abstract that the claims are fiercely overblown. If you're a scientist in the United States or a science student, you may want to brush up on your French. In the years leading up to World War II and in the aftermath of World War II, the United States benefited from what was then called the brain drain from Europe. Europe was in ruins. There was no science funding, and many towns that had formerly housed major university research departments. And so many Europeans, including many Germans, of course, Germany was the most smashed up of the European countries, came to the United States. That was called the brain drain, and it was great for us because we got good scientists. Well, France has taken a page from our book, and not only a page from our book, they've just enrolled in just one university, which is the main science university, Marseille. Big university. It has 80,000 students. They like to build them big in France. They have received about 300 dossiers from Americans, along with cover letters, American scientists, describing the research situation and wanting to come to France. Reading what the person whose job it was to review these said, the hardest part of this episode were the heartrending messages of people who were not taken by our department. Some of their colleagues will probably be able to find solutions in other universities in France or Europe, thanks to a program called Choose France, which is being widely promoted at United States universities, and also possibly scholarships and research grants. They are under such pressure. There are grants for colleagues who work, especially in the domain of climate change, have been completely effaced, completely stopped. Their colleagues can't work anymore. Those who are still hanging on, people are demanding that they justify their salary, and these are basic science researchers. The basic science is the justification of their salaries. So far, Marseille Université has chosen 31 researchers to bring in, all of them very high-level senior researchers in the environmental sciences, in humanities, because, of course, if you study gender or history or geography, well, that's woke. And so you're probably losing your grants because you use the word woman in the title of the grant. That's happened, by the way. And let me tell you, as a 70s-style feminist, I'm not happy about the idea that women equals woke. I don't think woke is a problem, but I sure think that gutting our research in the United States is crazy. Okay, who else is leaving? Biology, health, epidemiology, immunology, and from NASA, and joining the astrophysics lab. I thought we were in a space race, so losing our NASA scientists strikes me as drastically, all of the words that rhyme with stupid, but also just non-strategic and a danger to national security. So those scientists are packing up their marbles and flying to France, and it's not just an isolated university. This is happening all over the world. The Arabic nations, they're picking up quite a few researchers too. And we're just hemorrhaging here. We're hemorrhaging scientists. They won't move back. That's the thing. This is like chopping down redwoods. You don't get giants in their field sprouting from undergraduates who will take a long time to become giants in their field, assuming that they are able to because their field is still funded. Okay, I am taking a breath. That was the soapbox. We'll shove it over into the corner. Our next story, and this is, I like the category of old drugs with new indications. Diabetes, as you may know, is a growing epidemic, and prediabetes is going up at an even greater rate. And the prediabetes is contributing to the rather alarming increase in things like colon cancer and breast cancer in younger people. So the ripples are spreading. There is a drug that is literally as old as aspirin called Salsalate. It was suggested as a possible treatment for diabetes as early as 1876. And most recently, a double-blind, well-designed trial in 2013 showed that it is effective. Salsalate belongs to the salicylate drug class. It's a first cousin of aspirin. These inhibit something called 1-kappa B kinase. This inhibits a thing called the NF-kappa B cascade. This is how inflammation gets rolling. So if you inhibit the series of steps that lead to the production in the cell of inflammatory cytokines, which are chemical signals that carry a fire up the flamethrowers, boys message to the white blood cells, well, you reduce inflammation, but you also decrease insulin resistance because that too is connected to NF-kappa B. Recent short-term trials have shown that 3 grams to 4.5 grams of salsalate therapy daily lowers insulin resistance and reduces the levels of glucose, triglycerides, and free fatty acids in the bloodstream with few, if any, side effects. This is a review article. I'm not going to go into details except that I did review the review article, and they talk about the various studies that have demonstrated that. And one of the things that I found really persuasive about this is that the significance levels with the control group were really, really substantial on fasting glucose. So the amount of benefit was really, really quite high and quite rapidly achieved. It's also going to be, I had not checked the prices, but this is a very old drug. My belief is that somebody is still making it and that no one has bought it up and jacked the price up. So this might be something to consider asking your doctor about. And you can cite the article in American Health Drug Benefits. And this is an older article from 2014, but I would still say worth taking a look at. Okay, well, surgical robots are making strides. Both, I guess the surgical robots are probably stationary, but they are now really making a major advance in taking out organs. And I think we talked about this very briefly last week. This was an AI-powered system that successfully removed, without any instructions whatsoever from a human, it figured out where to put the clamps and how to grab the gallbladder and how to get the abdomen open and how to close off the blood vessels and how to clamp and tie off the gallbladder. Got it all done. Part of the secret sauce here is that it was actually 2 AIs, one handling the vision and the other one handling the instruments. But the cool thing is talking together, if they missed the organ with the instruments, the vision one would pick it up and tell the instrument one to try again. So their next step will be doing this on a live animal and not killing it, and then practicing that, letting the AI learn all of the nuances of that and moving forward. So we've talked about AI. Now we're going to move to nanobots. They're here. They're really, really small, and they swim. So this article has the euphonious title of Pico-eukaryote-based biohybrid microrobots for active delivery in the kidney. Allow me to translate. A eukaryote is a cell like a single-celled parasite or one of your cells that has a nucleus. Bacteria do not have nuclei. A pico-eukaryote is a very, 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 very small eukaryote. And we're talking about 2.5 microns for the largest pico-eukaryotes and 1 micron for the smallest. Now, just for reference, a red blood cell is 7 microns across. So these things are really, really small. And what they did was they developed a biohybrid microrobot based on these pico-eukaryotes that acted as a cargo carrier to deliver things in tight spaces, like, for example, the filtering apparatus of the kidney. It had the ability to go through very narrow and windy three-dimensional networks, and once it got there, it stayed there and was able to resist it, to stick to the walls of these passageways and resist flow shear and move. Now, these microbiotes get where they need to be by being guided through ultrasound and magnets. They're based on algae. They have one study used them to get deep into the lung areas without being picked up and eaten by the immune system and cleared. It's called magnetoaerotactic. This has been used to deliver drug-loaded liposomes, little soap bubbles filled with cancer-fighting materials, into tumors. In this study, these hybrid robots were able to get through tiny little channels in the body, 3 microns. That's something that a red blood cell could not fit through, even by deforming. The reason they used these pico-eukaryotes is because they're like a sperm cell in the sense that they have a flagella. And as you probably know, sperm are also really, really, really small. But a typical spermatozoa head is about 10 microns, and the length of the spermatozoa is 50 microns. These guys are so small that their head is 1 micron. It's a tenth the size of a sperm. It can basically go anywhere in the human body and migrate out successfully into capillary tissues, and it actually makes pretty good time. So they were measuring the velocity of this. It can go 58 microns per second. Just do a little math. That's about 3.6 centimeters in 2 hours. It could thus traverse the entire kidney in a fairly short amount of time, about 8 hours. And because they persist in the body for 48 hours and can swim against the stream of the bloodstream, I think it probably just gets there along the very edge of the flow and somehow sticks. I'm not really sure how it does it, but the fact that it can do it means that it would take it about 20 hours to swim from your toenail to your earlobe. And this is so small that it could deliver drug, it could deliver chemotherapy, it could deliver nutrients, and it could deliver fluorescence, which means that it could light up areas of interest. This particular robot was able, using the magnets to guide it, they were able to inject it into the bloodstream and then guide it to the kidney, which following running a magnet across the surface of the body. They found only minimal amounts of this fluorescent material anywhere else in any of the organs, like the liver or the lung, which is huge in terms of demonstrating that a true targeted strategy for delivery of small molecules is here. And this is a big deal. I would certainly want to keep them out of the MRI machine, however. So let's definitely not have those in the body and swirl them around, because who knows where they might end up. So we have to wait that 48 hours before we do your MRI. This was from an anonymous writer in San Jose. The first thing it says is, ask Dr. Dawn, gabapentin linked to mild cognitive insufficiency and dementia, etc. Hi, Dr. Dawn. Here's a reference article. This retrospective study just came out, how gabapentin is associated with increased risk and incidence of mild cognitive impairment and dementia. I'm 70 years old, and I took 300 milligrams a day of the drug for over 2 years for sleep. In a head EEG, which was taken while I was still on the drug, my brain waves were slower than normal, causing the neurologist to encourage me to get tested and then go on anti-Alzheimer's drugs such as Aricept. Neurologist denies any effect of gabapentin on head EEG. I have since stopped this drug. So, first of all, I want to comment on the EEG message because the gabapentin stabilizes the nerve membrane, and so it keeps it from being spiky, and so it may, in fact, on certain of the EEG channels, show up as a slowing. So I want to be sure that I clarify that, because you're giving a drug that you would expect to essentially slow down part of the EEG, and it's doing that. But does it have any effect on cognition? And what this article does is it makes the classic cognitive error of confusing correlation with causation. This was a retrospective cohort study, which means they looked back over a database, and these were people from 2004 to 2024. They had data of the prescriptions. The abstract I'm reading related to this does not state where this was done, but apparently they knew how many prescriptions for gabapentin people had. So I'm assuming a Kaiser or a country where they actually have a consolidated database, unlike the United States, which is balkanized by, actually literally balkanized by law. Go figure. What they did was they looked at people with chronic low back pain who might have been given gabapentin for pain. So I first want to point out that the dose for pain is much higher, as much as 3 times higher than the 300 milligrams. In fact, the sleep dose for people with back pain, you're probably getting 900 to 1,500 milligrams of gabapentin per day on the average, so as much as 5 times more. The study did exclude people with dementia, epilepsy, stroke, or cancer, all things of which could, of course, affect cognition. And they looked across for demographics, comorbidities, and pain medications, because obviously if a person has diabetes, they may have that as also a driver of dementia. And they looked at the age and their prescription frequency. And the primary outcomes were dementia and mild cognitive impairment. They found an increased risk, but before we go into the data, let me just point something out. We know that in pre-dementia, which can begin, our data now show us as much as 20 years before the onset of measurable cognitive impairment, that one of the symptoms, besides elevated tau protein in some individuals, is we can measure that there is insomnia. The ability to fall asleep and stay asleep is one of the first things that goes sideways. That and your sense of smell, which goes sideways as much as 10 years before you develop any dementia. So you've got this counterfactual about this data, which is that pre-dementia that will be measurable in 10 years is associated with insomnia. Insomnia is associated with the use of drugs to control insomnia, precisely why you were taking gabapentin. So many doctors prescribe gabapentin for insomnia, and the data, therefore, could be interpreted as pre-dementia causes insomnia, insomnia causes gabapentin prescriptions, and eventually shows up as cognitive impairment. So the gabapentin could very well be being caused by the thing we're measuring and blaming it for. Now, how bad were the effects? Well, what they found was that people who had 12 or more prescriptions for gabapentin, and they don't say what the time interval was here, would have a 1.4 increased risk. And mild cognitive impairment was 1.65. So I just want to say that the more dementia you have, potentially, or the more pre-dementia, the longer you're going to be taking gabapentin, and therefore there could be a false correlation between the number of prescriptions. So yes, it's not associated, and I totally disagree with the conclusion here, and I'm going to change one word. Gabapentin prescription in adults with chronic low back pain is associated with increased frequency of dementia and cognitive impairment. Physicians should monitor cognitive impairment in patients taking gabapentin. I have no problem with that. I would further add that when you test people for dementia and cognitive impairment, you have to take them off of their gabapentin and let it wash off, because we do know that gabapentin, even at low levels, is sedating and will probably interfere with test performance, maybe not as much as missing a full night of sleep, but probably also in a measurable way. More alternatives to knee replacement surgery are emerging. Now, the physicians caution that these aren't permanent fixes, but they may work well and allow you to put off your knee replacement. We start off with the story of Lane Heber, who had spent years in high school and college and also in the semi-pros playing football. So he was kind of in the cards to have bad knees. By the time he was 73, he was relying on periodic cortisone shots and hydrocodone to just get through twice weekly golf games and walks with his dogs. But he didn't want a total knee replacement. About 20%, 1 of 5 of knee replacement patients are unhappy with their outcome. That means, let's face it, 4 out of 5, that's 80%, feel better. But what really spooked Herbert was that a close friend died of complications from an infection 2 weeks after getting the procedure. So a lot of people have knee arthritis, maybe as many as 11% of the adult population of the United States, but a lot of people don't want to get surgery. So what else is available? There are new procedures that I think are very interesting. This started out about 10 years ago in the back with people with chronic back pain, and it's called nerve ablation. We have these little electrical radio frequency things that vibrate at 40,000 hertz. That generates some heat. So you can send a little tiny wire into a tissue and get it into the nerve and then vibrate it. Just ablating the nerves that are causing the pain is a reasonably good idea. So what this new procedure does, it's done under local nerve blocks, so you don't even have to be asleep. So some lidocaine and some Valium will do the trick. They make 2 little incisions on either side of the knee, and they use a tiny endoscopic camera to find the 4 nerves that send pain signals from the knee. They then cut the nerves and reattach them to the surrounding leg muscles. So they cut them and pin them so that they can't reattach to each other. Attaching the sensory nerves to the motor nerves actually causes a reaction in the brain that tricks the sensory nerves temporarily into thinking that they are motor nerves, and so they no longer transmit pain signals. It's almost like rewiring your stereo system, or back in the day when we had speakers and amps and preamps and turntables and all of that stuff. You would go behind your speaker system and there was just a rat nest of things. And I'm sitting here in a radio studio, and I assure you, there is a rat nest of cords on the other side of my screen here. And they all connect very important things to very important things. But the idea that you could trigger a reaction in the brain that would cause the sensory nerves to start behaving like motor nerves and stop sending pain signals is pretty amazing. They've done it starting in about 2020. It's been done in about 200. This is a breakthrough procedure. It's one doctor who's kind of evolved this. This is a doctor named Joshua Husted, and he's out in Arizona, but he is teaching other doctors to do this. There's another doctor named Dellon who has a similar procedure, and that's being taught at medical teaching hospitals. So this type of nerve denervation, unlike the type that's done in the spine, is permanent. And they've got, obviously, if it was started in 2020, then we're talking about 5 years. So denervation using the old technique, the radio frequency ablation, that'll work for about 6 months to a year, and then it has to be treated again. So this one surgery is kind of intriguing and a breakthrough. But of course, it's going to take a while to ramp it up to the point where there are surgeons available to do it. In the meantime, the radio frequency ablation is probably better than getting a steroid shot. Doctors have already been using embolization, which is blocking blood vessels. This one worries me a little bit because you're blocking blood vessels to the genicular artery. And so it is because when you have a lot of inflammation in the knee, you get abnormal blood vessels, extra blood vessels, and these blood vessels carry nerves on their surface, and they get exposed to the inflammatory chemicals that were being released in the first place, the cytokines, which we've already talked about this show. And so the new blood vessels shouldn't be there. So you can ablate them by essentially putting clotting them and injecting them with an agent. I believe they're probably using onyx here, which are used for venous fistulas. And the idea is you put something in there that hardens up and doesn't break down. And like I said, this genicular artery embolization has 4-year data. It does not have an increased risk of infection now that people's learning curve has gotten to the point where it's routinized. So lots of different things to explore for trying to maybe push that knee replacement down the road a little bit. Regular listeners will know that we have a medical residency here in my town that I was part of starting and am very proud to be on the faculty of. And this is focused on providing medicine for the underserved community, particularly innovative, semi-alternative interventions like osteopathy and functional medicine. The world's richest woman has opened a medical school backed by billionairess Alice L. Walton, who is the heir to the Walmart fortune. There is a new medical school in Arkansas that is based on a radically different approach to medical school, focusing on preventative medicine and whole health principles, caring for and treating, I should say, the entire person and all of the factors from their mental health to their living conditions and lifestyle choices that contribute to well-being. Here's a fun fact for you. Experts have noted that as much as 80% of medical education focuses on biology, and about 60% of premature deaths aren't due to biology. They're due to behavioral factors impacting biology, like lifestyle habits and diet and exercise and smoking. So they interviewed for this article several of the incoming medical students. I believe that it is 48 students for the first year's class, and this is pretty good. Walton is covering tuition for the first 5 graduating classes, and she's really hoping that some of them stay in Arkansas, just as we're really hoping that some of the people we're training stay in Santa Cruz. And the building is beautiful. I mean, this sounds great. They've got a wellness studio, a gym, healing gardens where the students can study, growing gardens for producing healthy foods, and a reflection pond. It's on the grounds of the Walton family property, which is undoubtedly huge. There's also a forest, and on the other side of the forest is the Crystal Bridges Museum of American Art, which is where Walton's art collection is. And one of the innovative things they're doing is the doctors will actually get some art training, which is something I'm doing with my residents. If you want a humanitarian physician, you've got to teach them the humanities. And, you know, a lot of the people that I'm seeing are so laser focused on science and STEMI and all of that, that they haven't learned, they maybe haven't studied a second language. They haven't, they learned about reading for fun. They don't know much about their creative self. And that's really, I think, something that has been an enormous benefit to my spirit. I call it spiritual acumen, my ability to read people, to understand different lives, and to have sympathy for them. Students will actually take a class that involves drawing one another and studying pieces in the museum. And these have been shown in psychological studies to increase skills of observation and empathy. We're doing that too. We have a teacher who's showing them a painting, telling them a little bit about the background of the artist, and then having them look at the painting and describe the expressions on the face, what the artist might have wanted to convey, what emotions are evoked when they look at this. And they spend a whole, I think it's half an hour just on one painting, talking about it, thinking about it. And it's an amazing exercise, something that I think we should all maybe give ourselves a chance. But certainly, if we're trying to get people to be thoughtful and empathic, art gives you the opportunity to do that. Right now, medicine incentivizes us to respond to patients' symptoms. First of all, order a bunch of tests and procedures, which now that the means of production are all owned by a single entity, including the purchasers of the products of the production, that is to say, you pay the doctor who orders the CT scan, there's certainly perhaps a perverse incentive not to discourage the doctor from ordering the CT scan that you're going to get paid to do. Alice got a real big dose of this, a rich and privileged woman, but in the 1980s, she had a terrible car accident. Then she had a bone infection, so lots of antibiotics, multiple surgeries, screwed up her microbiome, although it doesn't say that in this article. If you have a bone infection, you mess up your microbiome. That causes increased inflammation. That impairs your absorption of vitamins and minerals, and it slows down your bone healing for example. We're in a death spiral here in American healthcare. We need to pull back. We've got healthcare deserts where hospitals can't make ends meet because they don't have enough well-insured patients. They're in rural areas. They're going to have to get by on Medi-Cal and Medicare. And by the way, Medi-Cal just got cut majorly. And we stand to lose so many hundreds of hospitals in rural areas. Arkansas is 48th out of 50 in its share of adults in good health. It has the highest maternal death and teen birth rates in the United States. And by the way, our maternal death rates and teen birth rates are a scandal among advanced industrialized country. We have a lot of work to do to even count as average on these. Alice has also founded something called the Heartland Whole Health Institute, which focuses on research, advocacy, and education about preventative care. And now they're going to be training people. I just want to take my hat off. I guess I wear lots of hats, so I'll take them all off and wave them in the direction of Alice, because she has done something really amazing in setting this up and tying it together with art and making art available to the poor of her area. And I just can't say enough good about this. So if you engage the doctors with the community, which we're seeking to do here, it infuses the training with the reason that we all went into medicine. We went into medicine to help people, but people can become abstracted and become diagnoses in the modern world. With this program, the students will never lose sight of why they became physicians, and it helps broaden their role as a healer, not just a disease treater, but also healing family situations, addressing inequities, helping with the food supply. The students at this new medical school start community service work on their third day. They are all expected to be of service, to keep volunteering. Pre-meds do lots of volunteering. Very few of them keep volunteering when they get to medical school. Some of us do, but it's hard to find the time. And the same thing with residency. If you think about it, medical school and residency for primary care, together, that's 7 years. So you might have been doing some volunteering in the community, but 7 years is plenty of time to fall out of the habit. Well, that's about all for this week's podcast. Please go to AskDrDawn.com for news about our future plans. For now, this is Dr. Dawn saying so long and stay healthy.
Ask Dr. Dawn is brought to you by Jiva Media. Production and editing by Charles Bansky. Music by John Scoville.